Level up your AI skills with the RSNA Imaging AI Certificate Program. Our case based courses are designed to help you gain confidence, improve efficiency, and advance your career in this rapidly evolving field. Due to popular demand, we're extending our special RSNA member only offer of 25% off enrollment for any AI certificate course with promo code MEMBERAI25. Learn more at rsna.org/AI-certificate. This special offer ends November 29th, so act now.
I want to welcome everyone to RSNA Radiographics podcast. My name is Jack Jennings. I'm from Washington University in St. Louis. I'm a musculoskeletal, both diagnostic and interventional radiologist, and have been for my career. I would like to thank Dr. Menez and her team for inviting me to discuss thermoprotection techniques and musculoskeletal ablation. This topic is based on an article that was published in Radiographics by Peter Thurlow and team about thermoprotection techniques for image-guided musculoskeletal ablation. And this is a topic that I'm very passionate about because more and more over the past decade, percutaneous ablation is being used for the primary treatment of both benign and malignant musculoskeletal lesions for both local tumor control and for pain palliation. And as more and more of this ablation is being adopted, I think we need to highlight and emphasize the need for thermoprotection techniques, how to stay out of trouble. I always say it's easy to put the needle down and freeze or heat something to kill, but often a big chunk of time and expertise is in how to stay out of trouble and how to protect vital structures, that is, nerves, adjacent organs, vessels, etc. When it comes to percutaneous thermal ablation, there are multiple modalities. Initially, it was radiofrequency ablation that started in osteoid osteomas, benign lesions, and then went on to treat cancer lesions. And then a cold-based solution came with cryoablation. Those are two foundation ablative modalities that are being used for percutaneous ablation. Microwave has come into the scene, as well as MR-guided ultrasound. That's another form of non-thermal ablation. Lasers, less used in the United States, but those are kind of our big ablation modalities. And when you're talking about musculoskeletal, you're talking predominantly bones, but we're also talking soft tissues. And it's critical for us to know the adjacent neurologic structures. This is a plug out to my good friend, Nick Kurup, who there's a radiographics article, my goodness, it's probably now over a decade old, about critical nerve structures when it comes to ablation. And I can't recommend it enough. I give it to my fellows and to my residents. It's a radiographics article by Nick Kurup, Kurup. It's a great anatomic lesson of critical nerve structures. When you are considering doing an ablation of a musculoskeletal lesion, there are many things you need to keep in mind. You need to keep in mind what form of ablation modality are you going to use? Are you going to use a heat-based where you will not see anything on CT imaging guiding? Or are you going to use cold-based or cryoablation where you will see the ice ball sometimes within the lesion, but often not, especially in dense bone, that is long bones or even spine or in blastic lesions. But you will see the ice ball as it extends beyond the bone. So that's one thing to consider, is what modality are you going to use? The second thing is the lesion itself. How big is the lesion? How many probes are you going to need? Is there soft tissue extension? And does that soft tissue extension or bone approximation to vital structures warrant thermoprotection techniques? When we're talking about things to protect, we're talking about tissues at risk include spinal cord and spinal nerve roots, peripheral nerves. In the thoracoabdominal pelvic region, we got bowel, bladder, the hollow visceral organs. Bowel is super susceptible to thermal injury. When we're in the joints, the articular cartilage, bones, subchondral bone, growth plates in kids, and skin. Skin's the one that I always consider on every case. And don't forget about it in both the heat and the cool-based lesions. In considering the challenges in localizing peripheral nerves, you will often need a good MRI prior to the procedure to know where that nerve is and where your ablation will go. The other important thing is organ or muscle cross innervation. And what does that imply? Like in the sacrum, if you were to have ipsilateral nerve injury, you're probably going to be okay versus bilateral sacral nerve injury. The other critical component when you're talking about thermal injury is, has there been prior surgery? Has there been previous radiation? These will lower the tolerance for nerves and soft tissue injury. Very, very critical. And that sometimes will require you to dig into the charts and to figure this out. Where was their radiation field? You can reach out to the oncologist. Now let's talk about thermoprotective techniques. You have both passive and active. And you will always hear me say, especially with heat-based modalities, patient biofeedback is the best protective technique, especially when you're dealing with the spine, spinal nerves, and peripheral nerves. Heat is very, very toxic to nerves. Patients who are under mild to moderate sedation, at that point, when I get close to the spinal canal or in the pedicles, the nerve roots or the peripheral nerves, I lighten the patient up, they will respond. They will tell you they feel a burning pain in that nerve distribution. Also, why it's important for you to know the neuroanatomy. So, patient biofeedback, do not underestimate it. When I look back at all the ablations over my nearly 20 years of practice, when it comes to spine, over 99% were done with conscious sedation. Obviously, there are certain cases that I had to do with general anesthesia because of, patient could not tolerate. However, the majority were done with conscious sedation and patient biofeedback. The other thing is clinical assessment, right? If I'm freezing near the skin, putting my hand on the skin, looking at the skin to see if there's freezing of the skin. Is there frosting? Is it blanching? So you being actively involved with both your senses and with patient communication and biofeedback, to me, is paramount in every case. Another form of passive thermal protection is temperature monitoring. You're going to have continuous real-time, precise interprocedural temperature monitoring in the vicinity of the threatened structure. How is this done? Well, we have thermocouples, and these are thermocouples separate from those probes. There are certain probes that have thermocouples built into them. I'm talking about separate thermocouples that you place in the neuroforamina, in the epidural space, close to the peripheral nerve, in soft tissues that are critical values, so you know the temperature of the surrounding soft tissues adjacent to that vital structure. You can put them directly. I like them coaxially through a dual or multi-luminum cannula, because then I can also do passive, meaning for cooling or heating, I can inject through that same cannula in the region. So I'll often put them through a 10 or bigger gauge needle with a dual lumen or multi-lumen catheter. And this will help you get the temperatures and inject through a single access. So let's talk about temperature monitoring. What temperatures do we care about? The risk of thermal injury is directly related to the type of nerve fiber, with slight motor dysfunction developing at 10 degrees Celsius and mild sensory loss at 7 degrees Celsius. And both nerves cease to function between 0 and 5 degrees Celsius. At the maximum end, temperatures registered by thermocouples at any given stage of the procedure, if you're above 45 degrees, so heat-based 35, 10 degrees cold, you will lose motor function. What we've seen with ice is the myelin is much more tolerant to cold temperatures, and you will get reversal of function, right? 45 degrees Celsius, and if you get 60 degrees Celsius, you get protein denaturation, and you will not get return of nerve function. I will tell you, in spine, initially, I think it's been this 13, 14 years, maybe even 15 since we did the first spine ablation, I used temperature monitoring. I do not now, and have not for over a decade, because I feel so comfortable with patient biofeedback. But I still will use thermocouples with cryoablation if I'm near the brachial plexus, sometimes in the spinal canal. So just keep that in mind. Another form of passive thermoprotection is neurophysiologic monitoring. That's where you do use intraoperative neurophysiologic monitoring, which includes transcranial electrical motor evoked potentials and somatosensory evoked potentials. And this allows early detection of impending neurothermal injury. The Mayo Group, the Crew Group is involved with this, and the WashU Group have published on this in JVIR. If you want to read papers about this, but this is something I do on the majority of cryos in the vicinity of any nerve. I will tell you, obviously, this requires general anesthesia, so you lose any biofeedback. But what I will tell you is, and what we showed in our publication is that while dropping out of the nerve signal doesn't always make physiologic sense, it's indicative of impending nerve thermal injury. You obey it, you stop, you wait for recovery to begin. If you don't get recovery, you terminate the procedure and continue warming if it's cryoablation or cooling if it's heat based. We work closely with our neuromuscular electrophysiologists and have for, almost going on 15 years. It's a great relationship. I do understand that these can be challenging to get and not readily available in a lot of hospitals. However, I really think it's paramount to use these, and it will prevent you from impending catastrophic nerve injury. Motor evoked potentials are stimulated cranially over the motor cortex and recorded on targeted myotomes. If I'm doing just a acetabular lesion near the sciatic nerve, they won't do the entire, above there. They'll do both because you want to have the other side for comparison. So do everything south of the sciatic nerve. Makes sense. The somatosensory evoked potentials are stimulated peripherally by using these adhesive surface electrodes. Can't tell you how much importance I find with this. If warning criteria are met, I discussed prior, ablation should be terminated. If it's cryo, do your active thaw. If they normalize, then they're considered transient. Unrecovered tracings are associated with increased risk of neurologic injuries with sensory deficits or radicular pain, and ultimately possibly motor deficits. Key places, if you're in the spine, especially posterior elements or pedicle or posterior vertebral body, critical. Posterior acetabulum, don't forget that sciatic nerve sits right there. Obturator internus, you have the obturator nerve. Anterior acetabulum, you have the femoral nerve. The ilium, you can get the femoral nerve, and then you have the ilioinguinal, iliohypogastric nerves. So all things, again, going back to that Crew et al. Paper, super important. Spending time with your electrophysiologist to look at the neurophysiologic monitoring, look at the SSCPs and the MEPs tracings, to look for motor criteria, to look for baseline increase. If your voltage is going higher, meaning you need higher voltage to get that tracing, critical. So those are passive. Passive, again, to reiterate, we have biofeedback, we have clinical evaluation, skin is the example, and we have motor and somatosensory evoked potentials. Active thermoprotection, this may be performed prophylactically or when passive thermoprotection techniques indicate impending thermal injury. I would argue get them ready prophylactically. I think that's very key. Strategies include thermal insulation and thermal modification. Thermal insulation techniques are performed to increase the distance between non-target vulnerable structures and the ablation zone by displacing the at-risk structure or creating a non-conductive insulating barrier to prevent undesired thermal propagation. Thermal insulation may be achieved with pneumodissection, that's carbon dioxide insufflation, hydrodissection, fluid insulation, and possibly inflatable balloons to interpose between. This technique may be implemented for neurothermal protection, as we talked about, thecal sac, epidural space, neuroforamina, and peripheral perineural spaces, and insulation of other soft tissues such as bowel, bladder, and skin. Pneumodissection is most commonly achieved using carbon dioxide. And why? What are the advantages of carbon dioxide over air? Well, it has a lower thermal conductivity compared to air, almost 40% lower, and provides excellent thermal protection. When I go up to see my colleagues up at Mayo and Rochester, while everything else is frozen, air is not, and CO2 is definitely not, even though sometimes feel like the air is frozen. Carbon dioxide is highly soluble in blood, approximately 20 times more soluble in oxygen, minimize the risk of embolization. That's why we sometimes use CO2 in vascular procedures. Safety profile in large volumes. I will tell you in the abdomen, just like with endoscopy, you should measure temperatures. I think it's 10 millimeters of mercury. You should not want to get higher than that. And finally, carbon dioxide gas is readily available and not expensive. Hydrodissection fluid is often admixed with contrast, 2 to 100, whatever dilution you want. You don't want it too diluted, but you want it so you can see it both on soft tissue, but even on bone windows. We do it a lot with subcutaneous and bowel-related, abdominal-related structures, as well as bladder. Hydrodissection during radiofrequency ablation, members should be performed with non-ionic, that means not normal saline, but D5W, so dextro, 5% of water, because sodium chloride can result in electroconductivity and create a plasma field, which can result in undesired ablation zone expansion and energy propagation. Balloon interposition may be used for thermal insulation of soft tissues, predominantly used in bowel, can be used in the spinal cord. It's useful when reliable insulation can't be achieved with hydropneumodissection. Remember, with hydrodissection, hydro meaning fluid can freeze, so keep an eye on that. That's why having contrast, you can see the ice ball going into the area that you're dissecting. Active modification of temperature, either cooling or warming at the vicinity of the threatened structure, is very critical to keep the temperatures near body temperature. I will also tell you I use fluid myelography or epidurography, and it also helps with visualization and displacement of the nerves or the thecal sac. Intra-articular thermal modification, I believe, is very critical in intra-articular structures to minimize chondrolysis and osteonecrosis development from subchondral bone involvement, as well as physeal and those who are skeletally immature. And then skin, we have this, what we call the bird bath. So it's a warmer that keeps saline at a constant warm temperature. I use surgical towels that I can quickly put on and replace, and I can lift up and visualize the skin and feel the skin. So we've done this transformation over the last, 4 years with these OR warmers. Like I said, we call it the bird bath, but it's very helpful to use and has worked out well. So these are basically all the active thermoprotection techniques. And as I said, hydropneumodissection, direct skin protection, physical displacement in a position with a balloon. In addition, so with passive and active, you're set up with an armamentarium to minimize musculoskeletal ablation of benign and malignant lesions, thermal injury when treating lesions. MSK interventional oncology is one of the most rapid growing areas in interventional radiology. And when it comes to metastatic osseous bone disease, I think it's around 17 to 18% of the total direct medical cost related to the National Institutes of Health is the economic burden of bone metastatic disease. And what we're trying to do is we're not only trying to treat pain, but we're trying to prevent skeletal-related events. And also we're doing more and more of this for local tumor control. And that is especially in patients who have oligoprogressive or oligometastatic disease. So you really need to keep this in mind. And I will tell you, from our interventional colleagues out there, this isn't being done as much as it should be in the training program. So if you're used to just visceral, liver, renal, and some lung, this may not be your first thought when you get asked when you're in private practice to do a bone ablation procedure. But I tell you, paramount for you to consider this. And having done some medical legal work throughout my career, this has been the case in many of the cases that I've done, is these protective techniques were not used or considered. And I'll tell you another critical component for protective techniques during the procedure, CT guided, get imaging frequently. If you're near a vital structure, look at that ice ball every minimum 2 minutes. And the more critical and the closer to the structure, do it even more frequent and cut back on your percentage of argon. So in summary, this article by Thurl et al. Really discusses critical thermoprotective techniques. It's a wonderful summary of the ablative techniques we have, gives great pictorials of the cases in which thermoprotective techniques are paramount. And I really thank you all for your time and for listening to this. And I'm always available, Jack Jennings at WashU, for discussion on this. I want to thank Peter Thurlow and his team for this wonderful article and pictorial of thermoprotective techniques. And I want to remind listeners to rate, review, and subscribe to these podcasts. They're incredible. And I think it's a great way to learn when you're on that drive to see family or back and forth to work in the morning, just to sit there and listen. Thank you for Dr. Menyes and the wonderful things that she's done for radiographics over the past years and for our friendship. And again, thank you all for joining me for this time. Have a good rest of your day.